Ladies and gentlemen, good evening and welcome to Correct Movement for Better Health. I'm Dr. Kostopoulos and I would like to welcome you all to our program tonight. And I'm delighted to be today at the Mount Sinai School of Medicine at the Center for Neuromodulation and Deep Brain Stimulation. I know that the words sound very interesting and different, and everybody is wondering, what is the deep brain stimulation and neuromodulation? And we'll talk about that because I am delighted to have with me in today's program Dr. Barbara Sarantakis Changizi, who is the co-director of the Center of Neuromodulation of Mount Sinai School of Medicine and assistant professor of neurology. Dr. Changizi finished medicine at Duke University, her neuro residency at UCLA, and a fellowship at Albany Medical Center, where she took over the deep brain stimulation program. So, Dr. Changizi, welcome to the program.
Thank you. Thanks. Thanks for having me.
For joining us today. This is an amazing subject that we're going to talk about today. Very, very interesting and different. It's much different than hypertension and diabetes and low back pain that we usually talk about in this program.
True.
But talking about the subject of deep brain stimulation, we have to really start from one of the conditions that can be very useful at. And that condition is Parkinson's disease. So, Dr. Changizi, when we talk about Parkinson's, what is Parkinson's? Okay,
that's a great question. So Parkinson's disease is a combination of symptoms that in constellation in group are Parkinsonism. Parkinsonism is shuffling, it's slowness, stiffness, and tremor. And when those things occur in combination, we think that the patient has Parkinsonism. Parkinson's disease is the most common cause of Parkinsonism, that group of symptoms. There are some more rare syndromes that mimic Parkinson's disease, but the most common cause of that group of symptoms altogether is Parkinson's disease.
So in other words, somebody may have this constellation of symptoms that we call it Parkinsonism, but it is not Parkinson's disease necessarily.
Correct, correct.
And there may be many reasons, even medications that can cause these type of symptoms.
That's exactly right. So one of the reasons to see a neurologist or a specialist is to first determine what exactly is causing that. And there have been people that we've seen who have been misdiagnosed. For example, they may be clumsy, they may think that they're weak or that they've had a stroke, but in fact their strength is fine, there is no actual nerve damage, for example, in the hand. They actually have slowness and poor dexterity from Parkinson's disease, and they need to see a specialist to actually diagnose. And the prognoses for the condition that is causing the Parkinsonism differ. So the best prognosis if you're going to have Parkinsonism really is if you have the classic run-of-the-mill Parkinson's disease.
Right. Dr. Changizi, since you mentioned about the tremor being one of the symptoms of the Parkinsonian symptomatology,
Sure.
There are a lot of people who have some type of tremor. Let's say they try to approach a cup or a pen, and as they are approaching, they may have a little bit of tremor.
Sure.
Can we discuss about the difference of that type of tremor versus the Parkinsonian type of tremor?
Sure, sure. So there are different reasons for having tremor that come from different parts in the brain and have different diagnoses. So a Parkinsonian tremor classically it starts off on one side of the body. In other words, it's called asymmetrical tremor. It will start off in one hand or one leg. It's known as a resting tremor and a pill rolling tremor. So, for example, the classic is a tremor that resembles this. As the disease progresses, it will spread to the other side. But also a classic feature of a resting tremor, which is, you alluded to this, is that it goes away when you have changes in posture, you use the hand. So for example, when they are writing, perhaps the other hand will shake at rest while they use this hand, which will dampen as soon as they change posture. this can be compared to essential tremor, for example, a very common diagnosis and something we also treat in our clinic for movement disorders, where it's a postural tremor or action tremor. When you use the hands, that is when the hands shake, which makes things like holding a cup, using utensils, pouring liquids very difficult. That's a very different disease than Parkinson's disease, and it tends to be much more symmetrical. So it tends to spread, it tends to be in both hands with use of the hands, compared to a Parkinsonian tremor, which is in one hand at rest, and then over years will slowly spread to the other side.
And this is absolutely very important for people to have this distinction, because the fact that someone, especially either being an elderly person and having a slight type of tremor as an intention type of tremor versus the pill rolling type of tremor, as you said, it's very important as a distinction. At this point, I would like to ask Dr. Changizi about the specific cause for the Parkinson's disease. We know that the Parkinson's disease is a responsible part is a specific part of the brain, which would be what part of the brain?
Yeah, that is a complicated question to answer. We know that Parkinson's disease, it's called a movement disorder. And when we say movement disorders, we mean parts of the brain that control the quality or the abundance of movements. Hence, for example, one of the features of Parkinson's disease is slowness. So they tend to be the basal ganglia, which are structures such as the subthalamic nucleus, substantia nigra, the thalamus, the striatum. This is different than having a disorder that causes problems in the motor pathways, for example, having a stroke where you feel weak. So we know the parts of the brain, or the assembly line of the parts of the brain that are involved. We don't know, however, the cause of why those parts of the brain are having trouble, why the cells are having issues and why they're dying off. We do know that there's a lack of dopamine production because some of the cells that make dopamine are dying for reasons that we don't fully understand under programmed cell death. So we still don't have a cure or as good an understanding of the disease as we would like. We just have symptomatic therapies or things that treat the symptoms. My final part to that question would be that we don't know. We know that there are certain risk factors. For example, your genetics. Aging alone is the biggest risk factor. Men are slightly more likely to get it, and that there are some more rare genetic forms of Parkinsonism which are more likely to be inherited. But we think that it probably is due to a combination of some sort of environmental insult as well as a genetic predisposition or susceptibility that are affecting certain parts of the brain over years, and then eventually affecting part of the motor brain, parts of the brain of the basal ganglia that we just discussed, and then causing that constellation of symptoms that we were mentioning.
So is then this dopamine production decreased?
Yes, that's exactly right.
So in other words, we don't have enough dopamine.
Yes, that's one part of the motor features of it. Yes, yes.
So what I would like to ask Dr. Changizi, I would love to get that question. If it is just simply the fact that we don't have enough dopamine, why can't we just inject some dopamine and throw some dopamine in the body and get rid of Parkinson's? That would be a very fair question. But I have to ask her that question after we go to a commercial break.
Pain ruins your life. If other methods have failed, find the answer now, combining physical therapy with laser. The new laser technology erases pain and decreases inflammation. Hands-on Care Physical Therapy and its founders, Dimitrios Kostopoulos and Konstantin Rizopoulos, treat you today with the science and technology of the future. Hands-on Care Physical Therapy, Kostopoulos Rizopoulos, because we care for you.
This is the second part of our today's program, ladies and gentlemen, and I'm back with Dr. Changizi, who actually here name is Barbara Varvara Sarantakis Changizi. It's a Greek name, as you can hear, because although she doesn't speak any Greek, her father actually was from Greece. What part of Greece was he coming from?
He's from Nafplion.
Nafplion.
So,
Nafplion is a really great place.
It's beautiful.
Have you been there?
I have swam in the water and snorkeled, and yeah, we've been there, and we have a place in Athens now.
Okay.
So both, yeah, I love visiting.
What I love about Nafplion is that there's a beautiful promenade where you can sit and enjoy your coffee, and right in the middle of the water, there is a very little island.
Yes, yes.
That is called Burzi, I think.
I'm forgetting the name,
like
but yeah.
It's a beautiful little thing there.
And is the Greek word for ice cream, is it pagoto? Am I remembering that?
Yes.
That's, my father used to bring us for ice cream, and my sister and I used to sit on that and look at the water and have ice cream. So that's one of my childhood memories.
So we recommend it to everybody who is watching the show to visit this beautiful Greece.
Go to Nafplion.
Go to Nafplion, yes. So here is the question now. Why somebody who has Parkinson's, can we just give them a shot of dopamine, since dopamine is the problem, and get rid of the problem forever?
Okay, so there is no cure. That's a great question. There is no cure for the disorder because the brain is constantly not making enough dopamine. So you can give, there are forms of, there are injections that you can give that are dopamine agonists. In other words, they hit dopamine receptors and they work to treat Parkinsonism, but they are short-lasting. They are not, they don't have a permanent effect. There is no cure. We give pills because that's a form that's convenient and affordable. And in the early stages of the disease, you can actually take the medications very infrequently. For example, 1 tablet 3 times a day is sufficient to suppress the symptoms. It's not curing the disease, but it is quieting the tremor, stiffness, slowness. But as the disease progresses, what happens is as your reserve of cells that are capable of holding or storing dopamine and your brain evolves in response to the medication, fluctuations develop where you take the medicines, they take a while to kick in, you move excessively when they do kick in, which is why Michael J. Fox at times looks like he is moving excessively at the peak of his dose. And then the medicines wear off, and you are limited in lifestyle because you are taking the medicines every few hours. So if we had some sort of lifeline where you could have a medication on board at equal drug levels getting to the brain at all times, that would be ideal. But we're limited by the pulsatile, the blood levels of the dopamine. We also have to give it in a form that can cross over into the brain, past something called the blood-brain barrier, and also by the disease progressing. It is only replacing the neurotransmitter the brain doesn't make. It is not curing the actual cell death of the disease.
And from what I understand, another challenge that you have is that in the body, when you give that medication, there's an enzyme that will destroy essentially that dopamine that you are giving.
Correct.
So what do you do for that?
So whenever we give a medication called Sinemet is the trade name, we give it in a form called carbidopa-levodopa, and that is so that the levodopa, which is converted to dopamine in the brain, is not converted in the periphery or in the body. We want as much of the levodopa to get to the brain where the disease is as possible. So the carbidopa prevents that process. So if you get your pills for the Parkinson's and you look, you will always see 2 drug names in the pill. And that's always the form that we provide it in for that reason, to prevent the conversion of it into the body, which causes side effects.
Could we say that someone who is affected by Parkinson's, they will have to use whatever pharmacotherapy they are taking for the remaining of their lives, and essentially as the years pass by, the symptoms can become even more, or the other way around, the pharmacotherapy not as effective as it was in the beginning.
Sure, sure. So as the disease progresses and the dopamine reserve decreases, what happens is that they are on a cocktail of medication, all to promote this dopamine function, which is really also mainly aimed at the motor features of the disease. And they will take the medicines at more frequent intervals. So I have some patients who with more advanced disease where if they take the medicines, they do feel quite good. They're highly functioning, they're able to get up, walk around, garden, work, but they are limited to time intervals where the medicines are effective and then they wear off. And when we reach the limits of that medication, there's only so good that the best, what we call pharmacotherapy, can do. That's when we start thinking about other treatment options, which you had mentioned at the beginning. Things like deep brain stimulation. That's when they become surgical candidates.
And since you brought this up, let's talk about that. When somebody hears the words deep brain stimulation, it's like kind of a scary word. I mean, people are scared of having a pacemaker in their heart, but I mean, don't play with my brain.
Sure.
So what is this business of deep brain stimulation?
Okay. Well, so it is a pacemaker for the brain, I would say. That's the best way to look at it. What we do is we place there's a battery that goes into the chest that we're able to program through the skin. So it's under the skin, you don't see it. And there's wires that are fed up through in the skin and that go up to a screw here. There's a little hole that's drilled into the skull and a wire is placed into, in Parkinson's disease, into a structure called either the subthalamic nucleus or globus pallidus, and it's delivering pulses of energy, something called high frequency stimulation. And the best way to think about this—
So is that electricity essentially that is being delivered?
That's exactly right. And I guess the way to look at it is that in this disease, what studies have shown in humans and in animal data are that, that the brain is firing abnormally. It's firing in a way that is not allowing the normal circuitry that allows good quality movement to occur. And by interrupting that with this brain pacemaker, you are able to mimic more the normal rhythm of the brain so that you are able to function more like a normal person would without the disease.
So in a way, somehow, let's say that I want to make a specific movement, right? There is some part of the brain that makes that movement to go kind of faster to happen, and another part of the brain that kind of will inhibit that movement. And you're finding some sort of balance between these two? What
we are doing, there is a direct and an indirect pathway in circuits. In the basal ganglia, there's a cluster of organs or parts of the brain that are regulating the balance of movement, whether you move too much or you move too little. And those of us without the disease, we take it for granted. We move exactly when we want to move. People with Parkinson's have slowness. When they want to move, it is very difficult. They're rigid, they're tremulous, but they're also just slow. So there is a mismatch between the allowing the brain to move when it wants. And what DBS does is target a specific area that is overactive to allow that a more normal balance between those pathways, so that when the brain is saying, go ahead and move, pick up the pen, go ahead, walk, run, it's allowing that normal balance to occur so that the patient functions more normally.
Very, very interesting. Let's discuss for a moment, what are the specific benefits that somebody can have from the deep brain stimulation?
That's a great question. So the best predictor of response to DBS, or deep brain stimulation, is your response to dopamine. So the carbidopa-levodopa or Sinemet we were talking about earlier, for example, those symptoms that improve with that drug, which may include the stiffness, slowness, and sometimes tremor, are typically the ones that get better with the DBS. So the nice thing about the DBS is that unlike the medicines, which are swinging up and down in your blood levels and leading to yo-yoing between moving too much and moving too little and having those dyskinesias you had mentioned, the DBS is always on. Even while you sleep, it is always on. And so it is mimicking the effects of those drugs for all of those symptoms, and in fact may treat tremor better than the dopamine for various reasons. It is always in the background and always suppressing those symptoms so that you are not married to the timing of your pills in a way that you are before the surgery. It is actually better at reducing off time, time that your medicines aren't working, and reducing time where you are moving too much or on time with troublesome dyskinesia, far more so than best medical management.
I want to find out more about both how involved the surgical procedure is, and also how someone looks right after surgery.
Okay, sure.
But we first have to go to a quick commercial break.
Okay.
When a hand cannot grasp, one cannot hold another. When knees cannot bend, one cannot move freely. Because there is pain, there are people who have dedicated their lives in the science of the body and through the art of caring help restore people's lives. Hands-on Care Physical Therapy and its founders, Dimitrios Kostopoulos and Konstantin Rizopoulos, treat you today with the science and technology of the future. Hands-on Care Physical Therapy, Kostopoulos Rizopoulos, because we care for you.
Correct movement for better health, and this is the third part of our program. And if you have any questions, you can always call us at 718-626-2699. We'll be able to give you information about the program. You can recommend to us any type of topics that you would like us to discuss with you. And today I am at Mount Sinai Medical Center at the Department of the Center for Neuromodulation. And I am discussing with Dr. Barbara Changizi, who is an assistant professor.
Yeah, it's okay.
Assistant professor of neurology. And we're discussing about Parkinson's and deep brain stimulation. So at this point, I mean, we can see from what you discussed what the benefits will be for someone getting this procedure. How's the procedure itself? How difficult is it?
That's a great question. So the main thing that I warn patients who are considering this is that you are awake during the surgery, and there are good reasons for this. So the typical day that occurs here at Mount Sinai, the process is the patient comes in early in the morning. They've already had an MRI taken, which is a very high-resolution photograph of the brain. They have another picture called a CT that morning, and they have a frame placed on their head so that helps us map where in the brain to go. When they go to the surgical suite, they are awake, but we give them numbing medications, just like when you go to the dentist and you have some shots and you don't feel then the pain for the major procedure. That's exactly what happens during the brain surgery. So you don't feel anything other than pressure. Even though we are doing the operation, you don't see anything. So it sounds a lot scarier than it actually is. The surgery typically takes a few hours, just the greater part of a morning. Oftentimes you go home the following day. The reason that you're awake during the procedure is that we actually listen to the brain activity. That helps to tell us where in the brain we are. As we place the electrode in, we are listening to the different regions on the way down, all the different structures in the brain. And when we get to the target, which is the place that you have to stimulate that's responsible for the Parkinsonism to try and treat those symptoms, it has a very distinctive sound to it in terms of the electrical activity of the neurons or the brain cells. When we hit that, we know we're in the right place.
Is it a specific frequency, in other words?
Exactly. There's certain characteristic sounds of each part as we go down, and that's something called microelectrode recording. So we hear that, and the patient, we will move and manipulate the arm of the patient and so forth and listen to either tremor cells or response to the cells in the brain as we move the arm passively, and the patient will actually hear their own brain firing, and they don't feel any discomfort. The brain itself does not feel pain. It is receiving pain input from other parts of the body, but when you place the electrode inside the brain does not feel it.
Right.
Yeah.
It's very interesting. But what is the purpose of keeping the patient awake? Can you test the effectiveness of the procedure?
That's true. Yeah, so the first part is listening to the recordings to know that we're in the right place. If they are sedated, that activity of the brain firing is quieted, so we don't hear it. So one is just anatomical placement and accuracy. The second part is, once we finish and we place the macroelectrode or the stimulator, the lead, We then hook it up and we actually stimulate or program, we apply some energy right there on the table while they're in the operating room, similar to what we would later do in the office when we formally program. And we can actually, on the operating room table, get a good response or treat their Parkinsonism by sending current right there and then. And that helps to see, number one, we make sure we don't have side effects we wouldn't want later on once we've closed the brain up and we've permanently placed it. We also see that we have efficacy or a good response. So we will see the tremor actually dampen down right there on the table. We'll see their tone improve. They'll stop being so stiff on the table. And the patient who is awake will actually feel the Parkinsonism on the opposite side of the body that we're operating on melt away right in front of us as we stimulate.
This is absolutely amazing. And as a patient on that operating table, I can only fathom how in a way scary a little bit can be, but at the same time to feel the effectiveness at the same moment. I mean, you have to feel very excited about
most of our patients are absolutely, it's an emotional experience because this is a life-altering procedure.
Yeah,
it really is.
It's absolutely amazing. It sounds very exciting. And from what you're describing, probably very effective. The question is, how long does this last? Is it possible that after a while, no matter the stimulation, it's not effective?
So that's a mixed answer. For the most part, studies have shown, this has been FDA approved, I believe, since 2002. So we're now just seeing the longitudinal data. In other words, the follow-up of the patients years and years and years out after having numerous patients undergo this for over a decade. And the studies show that 5 years, 8 years, 10 years out, certain features, tremor, stiffness, and slowness, actually continue to be extremely well controlled with the DBS, even for that length of time. However, it is not a cure for the disease.
Right.
So I do tell patients that it will not cure the Parkinson's. Other features, were you to turn the stimulator off, you would see the Parkinsonism return underneath if you turn the stimulator off.
Yeah.
The other thing is that speech, balance, and cognition, or your thinking and memory, those unfortunately do decline as the disease progresses. They seem to be more complicated brain circuitry that doesn't have as clear benefit from the stimulator over the long term. Yeah.
Do we see any tolerance?
I would say no, it seems to have a fairly robust response for years out. Could you have some breakthrough that you have to increase the amplitude a little bit? But for the most part, patients stay at fairly good settings for the duration. Yeah.
Dr. Changizi, this is such an amazing topic, very, very interesting. And I know that definitely we're not going to be able to finish discussing about all depths and lengths of it in today's program, but definitely would like to invite you to come back in the future and discuss a little bit more about this and even see a little bit more of this, see some pictures or some video of that. Would love that, and I'm sure that our viewers would love that too.
Sure.
So thank you very much for joining us.
All right, well, thank you for having me.
Thank you.
It was a pleasure.
Ladies and gentlemen, our program, Correct Movement for Better Health, is coming to its end. We'll be with you next time. Please remember to call us at 718-626-2699 for any questions that you may have, and we'll be able to bring you in touch with Dr. Changizi. And also check our website at www.handsonpt.org.